Well, hi everyone. This is take two of the talk I did earlier today. Apparently, there were some paper shuffling that was quite distracting, and I'm really sorry for that. Ironically, I was concerned about my dog and my kiddos being noisy, but it was me that was making all the noise. So thanks very much to Michelle and to Randy, and thanks to all who have tuned in and who continue to protect our province. And not to sound like a broken record, but if we can see those slides again, Michelle. Great, thank you. And not to sound like a broken record, but I just wanted to remind everyone that we are already over capacity in terms of ICU beds. So credit to Ziad Faisal for these fantastic graphs. The message from Alberta Health in recent days has been that we are around 87% capacity in ICU. However, with a baseline of 173 beds and 201 people currently admitted to ICU, we're already well over capacity. And if I could have the second graph up, please. Great. And here's another graph to show where we might be in just a week's time. The curve here is depicting what may happen with COVID only. It does not capture any of the other reasons why people might need ICU care. And while it is possible to scale up capacity, as we heard earlier from Dr. Bakshi and Dr. Parks, it may come at a cost. Next slide, please. So for some context, this report from the Canadian Institute for Health Information, or CIHI, on ICU care in Canada was published in 2016. These tables show the top 10 medical and surgical conditions among ICU patients. You can see that there are a number of respiratory and cardiac conditions and procedures, and some types of surgeries that people with certain types of cancers might undergo. Notably missing from the tables, of course, is COVID. But I just want to make the point that there are a number of other reasons why someone might require ICU care, and these reasons haven't stopped during the pandemic. Next slide, please. So for further context, the average length of stay in ICU in 2016, and this is Canada-wide, was approximately 3 days, and approximately 33 of those in ICU required mechanical ventilation. Next slide, please. And this report by CIHI was published just a few weeks ago on August 26th and includes data from January 2020 to March 2021. It's important to clarify that these numbers are reflective of what was happening before the fourth wave, so before Delta. You can see from this table that the average length of stay in hospital was approximately 15 days. The report also notes that Canada-wide, of those who required hospitalization, more than 1 in 5 needed ICU care. Next slide, please. And for those who required ICU care in Alberta, the average length of stay in ICU was approximately 12 days, compared to 3 days in 2016. You can also see that people who needed ICU care were in hospital on average for about 25 days total. Also in Alberta, 64.5% of those in ICU required mechanical ventilation, compared to approximately 33% in 2016. The length of stay in hospitals and in ICUs will continue to impact healthcare capacity. Patients who are ventilated are likely to have longer hospital stays and more complex care requirements even after discharge. The American Thoracic Society reported in 2015 that critically ill patients who have been mechanically ventilated for more than 7 days are at greatly increased risk for functional impairment and mortality at 1 year following discharge from the ICU. And although I hate to talk about money at a time like this, it is relevant to consider the costs associated with hospitalizations and ICU stays, as the resources in our healthcare system are finite. The average estimated cost of a hospital stay for COVID-19 is approximately $23,000 and is more than $50,000 for ICU stays. Next slide, please. In terms of nursing capacity, according to the 2019-2020 College and Association of Registered Nurses annual report, there were approximately 38,000 registered nurses in Alberta. Of these, there are roughly 1,350 critical care nurses. Even before the pandemic began, many parts of Canada were already dealing with a nursing shortage. The thought that a nurse is a nurse is a nurse couldn't be further from the truth when it comes to ICU. Don't get me wrong, nurses have been stepping up throughout this pandemic. I know many nurses who have been working as nurse immunizers, me included, helping with contact tracing or working in long-term care facilities, even those with COVID-19 outbreaks. But working in ICU is different. Personally, I'm not sure how useful I would be in an ICU. I worry that I would actually add to the workload of the ICU nurses. The province plans to bring in nurses from other jurisdictions and reportedly is paying top dollar. Medscape recently shared a cautionary tale from the US where nurses are quitting their regular jobs in favor of travel nursing jobs where they are often paid far more than their regular pay. This has led to some tense working environments where travel nurses working alongside regular nurses are sometimes paid more than double what the regular unit nurses make. Imagine how well this will go over in Alberta, where nurses are facing imminent wage rollbacks. This strategy is likely to also contribute to substantially increased costs to our system. For example, at a hospital in Georgia, a respiratory therapist was hired through an agency to replace a respiratory therapist who accepted a travel position. The replacement came from the same hospital. The replacement came from the same hospital where the respiratory therapist had just gone to work. And basically, the two hospitals swapped respiratory therapists, but at double the cost. Next slide, please. I would be remiss if I didn't mention the impact of moral distress and moral injury that have become pervasive and I would say even ubiquitous in healthcare these days, irrespective of practice setting. Working conditions, being short-staffed, working with high acuity and very sick patients, witnessing patients die alone, the impact of visitor restrictions. It's not just impacting staff and critical care. Many of us feel moral distress knowing that we cannot provide the care that we want to provide and that patients and their loved ones deserve. Next slide, please. We talk about numbers, the COVID-19 numbers, the number of people in hospital or ICU, the number of ICU beds. Some people are good with numbers, and believe me, I'm grateful for them. I'm good with faces and names and the stories behind the faces and names. Some of you may have seen this Twitter thread on Friday, or you may have caught the interview with Ryan Jesperson yesterday. For those of you who don't know her, Julie Rohr is a young mother who has end-stage cancer. She has given me permission to share her story in these photos. She tweeted on Friday, "I'm an end-stage cancer patient, dealing with some of the most difficult decisions I'll ever make. I have to get my lung drained in order to breathe. Doc wants me to come to a hospital ER to do the procedure, but hospital ERs have COVID outbreaks. I am trapped. If I get Delta, these lungs are done for. They wouldn't even treat based on my condition. Do you see how this works? COVID vaccine deniers are getting my bed. The one I need to survive a little longer with my children and puppy." Here they are. Next slide, please. This is Julie with her beautiful family and her parents. Healthcare capacity is not only about COVID. A full hospital means that someone who gets in a car accident might have to be transported to the next nearest hospital and may lose precious time that might mean the difference between life and death. A full hospital means that people with treatable, even curable conditions may not receive the care they need. Please get vaccinated, continue to mask, please limit gatherings, and please always be kind. Thanks.
Any closing words, Reanne?
No, I just would like to thank everybody who's participating and tuning into these briefings. And again, so perhaps didn't have the paper shuffling, but I did hear a tweet or a message ding at one point. So I think that some of these distractions are perhaps inevitable. But I just want to thank everyone in the province who's doing all they can to protect each other. And really, I speak about cancer in my perspective from being the president of the Canadian Association of Nurses in Oncology. We know that people with cancer are at increased risk of bad outcomes if they get COVID-19. The case fatality rate for someone with cancer after COVID-19 infection is in the neighborhood of 20 to 25% compared to the general public, where the case fatality rate is between 1% and 3%. So my worry, of course, is for those people that are high risk in our communities and just wanting to do all we can to protect them. So wishing everyone to always, be safe, be kind, and thanks so much.